So this is a 58-year-old lady who was noted to have a mass in her right breast by her gynecologist. She was then sent for imaging and to see a surgeon, and the ultrasound basically confirmed this 3-centimeter mass in the breast and also noted a possible suspicious lymph node in the axilla. So she had a biopsy of both the breast mass and the lymph node, and it revealed invasive ductal cancer, estrogen receptor negative, progesterone receptor negative, and HER2 positive. So the surgeon had her case discussed at the tumour board, and it was recommended that she get referred for preoperative treatment, which is essentially what was done. So this is a reasonably common case that I think we see, and in general, for patients who have cancers that are HER2 positive, that certainly are more than 2 centimetres, particularly when they have a positive lymph node, they are very good candidates for a preoperative approach. And I think the majority of us would consider using some type of preoperative chemotherapy plus HER2-directed therapy in a patient like this to try and downstage the cancer, but also because we know that response in these HER2-positive cancers, particularly when they're hormone receptor negative, is very high and is associated with a very favourable prognosis for patients if you can get a complete response. So I think surgeons increasingly are referring patients to medical oncology when they've got HER2-positive cancers that are larger or node positive. So a patient like this that had a larger cancer and a positive lymph node, I think most times they would get referred to medical oncology initially. It's probably a little bit more common in academic centres, but I think it's becoming more universally used. I think you certainly could do surgery up front, but the preoperative approach definitely offers some advantages, and I think this would be very appropriate to send this patient over to medical oncology. In our centre, pretty much every one of our surgeons would refer a patient like this for chemotherapy and HER2-directed therapy, unless they were much older. I mean, this is a relatively young woman, but if they were maybe in their 80s, they mightn't do it. But I think, in general, increasingly we're doing this more and more. Yes, I think for a patient like this with a T2 cancer that's got a positive node and is HER2 positive and hormone receptor negative, I think referring the patient to medical oncology is highly appropriate. Because it offers the chance of downstaging the cancer. Also, we can see what the systemic therapy is doing, in terms of whether the cancer is responding or not. And additionally, we know that if we can achieve a complete response, which is reasonably likely in a cancer like this, with this type of treatment, that the patient will have a very favourable prognosis. So I would definitely agree with the surgeon for sending a patient like this over to medical oncology. I think that's the right approach for the patient.